ABC of X-ray chest Part 2 collapse of the whole lung and individual lobe. Dr. Jalal, Mohsin, Uddin. M.B.B.S, DTCD, FCPS, Pulmonology. Assistant Professor, N.I.D.C.H, Mohakhali, Dhaka. Index. Type of collapse Slide 3. Right whole lung collapse Slide 4. Left whole lung collapse Slide 7. Right upper lobe collapse Slide 9. Juxtaphrenic peak sign Slide 11. Golden S sign Slide 12. Left upper lobe collapse Slide 14. Luft-si-chel sign Slide 18. Right middle lobe collapse Slide 20. Collapse of lingual lobe Slide 22. Right lower lobe collapse Slide 24. Superior triangle sign Slide 27. Left lower lobe collapse Slide 29. Question 1. What type of lung collapse will be discussed here? Pathologically there are mainly three types of collapse. 1. Absorption collapse, which occurs due to endobronchial lesion or due to compression over bronchus, resulting blockage of lumen of the airway and ultimately develop absorption collapse. Here the radiological evidence of this type of collapse will be discussed. Other two types of collapse are 2. Compression collapse found in pneumothorax or pleural effusion, and 3. Cicatrization collapse found in fibrosis. Question 2. What are the radiological evidences of right whole lung collapse in PA CXR? 1. Loss of aeration of whole lung resulting diffuse homogeneous opacity, O, in all the zones of right lung field. 2. Mediastinum, M, including trachea, T, is shifted towards right, R. 3. Bronchial cutoff sign, S, suggestive of endobronchial obstruction. 4. There is presence of rib crowding of right thoracic case, usually resulting from long-standing collapse lung. 5. Loss of right lung volume. Question 2. Continue. 6. Obscuring right mediastinal and cardiac outline. 7. Obscuring right hemidiaphragm, silhouette sign. 8. Compensatory, C. Hyperinflation of left lung, hyperlucent lung field, low-lying diaphragm and wide intercostal space. 9. Prominent left pulmonary artery, P, as cardiac output passing through single pulmonary artery. Question 2. Continue. 10. Sometimes the right whole lung collapse may result severe compensatory hyperinflation of left lung, which may herniate to the right hemithorax, and right collapsed lung may be more compressed. Usually hyperinflated left lung herniate through anterior part of thoracic cavity, through retrosternal space, in front of the right collapsed lung. Usually right whole lung collapsed create right opaque hemithorax. Figure :1. But here is lucency in right upper zone due to herniated left lung. Red arrow. Question 3. What are the radiological evidences of left whole lung collapse in PA and lateral CXR? 1. Loss of aeration of whole lung resulting diffuse homogeneous opacity, O, in all the zones of left lung field. 2. Mediastinum, M, including trachea, T, is shifted towards left, L. 3. Bronchial cutoff sign, S, suggestive of endobronchial obstruction. 4. There is presence of rib crowding of left thoracic case, usually resulting from long-standing collapse lung. 5. Obscuring left mediastinal and cardiac outline. Black arrow. Question 3. Continue. 6. obscuring left hemidiaphragm, silhouette sign. 7. Compensatory, C. Hyperinflation of right lung, pellucent lung field, low-lying diaphragm and wide intercostal space. 8. Herniation of right lung towards left hemithorax. 9. Marked anterior hyperlucency, L, of the thorax on the lateral view. Question 4. What are the radiological evidences of right upper lobe collapse in PA CXR? Features consist of increased density in the upper medial aspect of the right hemithorax. A. Elevation of the horizontal fissure with or without superior bowing. B. Black line. Loss of the normal right medial cardiomediastinal contour. Elevation of the right hilum. The bronchus intermedius shifted laterally and appearing more horizontal than usual. Question 4. Continue. 6. Hyperinflation of the right middle and lower lobe result in increased translucency of the mid and lower parts of the right lung. 7. Elevation of the hemidiaphragm. 8. Crowding of the right-sided ribs. 9. Shift of the mediastinum and trachea to the right. Question 5. What is juxtaphrenic peak sign? The juxtaphrenic peak sign, also known as diaphragmatic tenting or Cardan sign, refers to their peaked or tented appearance, T, of respective hemidiaphragm which can occur in the setting of right or left upper lobar collapse. It is caused by retraction of the lower end of diaphragm at the level of major fissure or inferior pulmonary ligament. It is commonly seen in collapse of the left or right upper lobe collapse, RUL, but may also be seen in middle lobe collapse. The negative pressure of upper lobe atelectasis causes upward retraction of the visceral pleura, and protrusion of extrapleural fat into the recess of the fissure is responsible. It was first described by Kenneth R. Cardan. Question 6. What is golden S sign? The golden S sign is seen on PA chest radiographs. It is named because this sign resembles a reverse S shape, and is therefore sometimes referred to as the reverse S sign of golden. The appearance is that of right upper lobar collapse, the right upper lobe appearing dense and shifting medially and upwards, green arrow, with a central mass, M, expanding the hilum. These two changes together form a reverse S shape. Dotted sky blue line. Question 6. Continue. Common cause of lobar collapse is a hilum mass, bronchial carcinoma. Although typically seen with right upper lobe collapse, the S sign can also be seen with the collapse of other lobes. It can also be caused by other central masses, such as metastasis, primary mediastinal tumor, or enlarged lymph nodes. The sign was first described by R. Golden. Question 7. Describe lateral view CXR in right upper lobe collapse. On the lateral projection it is harder to identify as the soft tissues of the shoulders usually obscure upper zones, and the collapse is mostly medial. There is wedge, W-shaped opacification in the upper anterior chest. Elevation of the horizontal fissure, green arrow, and anterior bowing upper part of the oblique fissure, sky blue air, may be visible. Question 8. What are the radiological features of left upper lobe collapse in CXR PA view? When left-sided upper lobe collapses, it becomes a thin sheet of tissue and opposed to the anterior chest wall and appears as a hazy or opacity extending out from the left hilum and fading out inferiorly. Look at the upper part of the left chest. There is slight increase in radiographic density, D, than right lung, which is due to the increased thickness of the chest soft tissues as a result of collapsed left upper lobe. And density does not increase as there is compensatory hyperinflation of apical segment of left lower lobe. Question 8. Continue. Parts of the normal cardiomediastinal border, red arrow, may also be obscured where the left upper lobe, particularly the lingular segments, fades out the left heart border, sky blue arrow. The anterior parts of the aortic arch, green arrow, are also often obscured. Question 8. Continue. The left hilum is drawn upwards, resulting in an almost horizontal course, sky blue arrow, of the left main bronchus and vertical course, red arrow, of the left lower lobe bronchus. Non-specific signs indicating left-sided collapse will also be present, including elevation of the hemidiaphragm, beaked or tented hemidiaphragm, juxtaphrenic peaks sign, crowding of the left ribs, shift of the mediastinum to the left, posterior and left lateral rotation of the heart. Question: 9 What is Luft-si-chel sign? In some cases the hyperexpanded superior segment of the left lower lobe insinuates itself between the left upper lobe and the superior mediastinum, sharply silhouetting the aortic arch and resulting in a sickle-shaped lucency medially. This is known as the Luft-si-chel sign, red arrow. Question 10 Describe the features of left upper lobe collapse in lateral view of CXR. The left upper lobe collapses anteriorly, becoming a thin sheet of tissue opposed to the anterior chest wall and appears as a hazy opacity extending out from the left hilum and fading out inferiorly. The oblique fissure usually displaced anteriorly, orange arrow. There is associated anterior displaced of the left hilum. Question 11 What are the radiological features of right middle lobe collapse in CXR PA view? On CXR PA view the findings are subtle compared to the lateral view. CXR PA view include right mid to lower zone aeropacification, which can also be subtle. Yellow arrow. The normal horizontal fissure is no longer visible, as it has displaced inferiorly. A lordotic view may help identify the displaced fissure. Obscuration of the right heart border. Sky blue arrow. Question 11 Continue. Non-specific signs indicating right-sided atelectasis may also be present, but due to the small size of the right middle lobe it may be subtle or absent. Elevation of the hemidiaphragm. Crowding of the right-sided ribs. Shift of the mediastinum to the right. Red arrow. Displacement of the right hilum. Question 12 What are the radiological features of right middle lobe collapse in CXR lateral view? A lateral chest X-ray film confirms the diagnosis of right middle lobe collapse. The minor fissure, red arrow, moves down, and the major fissure, green arrow, moves up, leading to a wedge-shaped W opacity. Question 13 Describe radiological features of collapse of lingual lobe. Lingular lobe may collapse alone or in association with left upper lobe. In X-ray chest PA view there is increased opacity in left lower zone which causes obscuration of left heart border. A. In lateral view CXR, there is anterior displacement of lower half of oblique fissure, give rise to wedge shape opacity. W. Question: 14 What are the radiological features of right lower lobe collapse in CXR PA view? Features of complete collapse of the right lower lobe include triangular opacity, orange arrow, at the right lower zone, usually medially, with the apex pointing towards the right hilum. Obscuration of the medial aspect of the dome of right hemidiaphragm. Dotted blue line. Inferior displacement of the right hilum. Question 14 Continue. Descending into lobar pulmonary artery is not visible. Preservation of a clear right heart border. Inferior displacement of the horizontal fissure. Elevation of dome of diaphragm is not usual. Question 14 Continue. Non-specific signs indicating right-sided atelectasis may also be present. They include elevation of the right hemidiaphragm, crowding of the right-sided ribs, shift of the mediastinum to the right. Question 15 What is superior triangle sign? Superior triangle sign. Triangular density to the right of the mediastinum seen in right lower lobe collapse due to displacement of anterior junctional structures. White arrow. It should not be confused with a right upper lobe collapse. Question 16 Describe right lower lobe collapse in CXR lateral view. On the lateral projection the findings are usually obvious. Triangular opacification in the lower posterior chest. Right hemidiaphragm is obscured posteriorly and the lower thoracic vertebrae appear denser than normal. Oblique fissure displaced posterior-inferiorly. Orange arrow. Inferior displacement of the right hilum. H. Question 17. What are the radiological features of left lower lobe collapse in CXR PA view? In left lower lobe, LLL, collapse, increased retrocardiac opacity is found behind the left-sided cardiac shadow which give appearance of triangular ABC shadow in the posteromedial aspect of the left lung, which is called retrocardiac sail sign. The left lower's own opacification is situated medially with the apex, A, pointing towards the left hilum. Question 17. Continue. The LLL pulmonary artery and the left hemidiaphragm are also obscured. BC blue dotted line. A double contour, orange arrow, to the left edge of the heart is visible. The hilum shifts downward, and shifting of the heart towards left side and its rotation produce flattening of the cardiac waist, which is known as the flat waist sign. It refers to flattening of the left heart border, specifically the contours of the aortic arch and adjacent pulmonary trunk. Question 17. Continue. Non-specific signs of left whole lung collapse in left lower lobe collapse are usually also present, including elevation of the left hemidiaphragm, crowding of the left ribs, shift of the mediastinum to the left. Question 18. Radiological features of left lower lobe collapse in CXR lateral view. On the lateral view the findings are usually obvious. Triangular opacification, ABC, in the lower posterior chest. Left hemidiaphragm is obscured posteriorly and the lower thoracic vertebrae appear denser than normal. Lower thoracic vertebrae are usually more radiolucent than the upper vertebrae. Oblique fissure displaced posterior-inferiorly, orange arrow, but may be invisible with a severe collapse of the left lower lobe. Inferior displacement of the left hilum. H. Thank you all. End of ABC of X-ray chest Part 2. Learning Pulmonology. ABC of X-ray chest Part 2. Collapse of the whole lung and individual lobe. Dr. Jalal Mohsin.